Well, kia ora koutou. Sorry. Oh. Kia ora koutou. It's my great pleasure to introduce Unwin to give today's seminar. We're very fortunate to have Etty here. Etty's from Imperial College, London, and is been in New Zealand since September, is that right? So courtesy of 2 weeks in MIQ, and Etty's going to give us a British perspective on modelling COVID-19. So over to you, Etty.
Okay, thanks. Just a little bit about who I am. So I'm not an infectious disease modeller by background. When I was doing my PhD, I didn't know anything about infectious disease modelling. I'm actually a mechanical engineer by background. My PhD was in modelling systems and uncertainty, which got me really interested in looking at different methods, ways you can quantify uncertainty in large scale systems. Then at the end of my PhD, wanted a bit of a change, just was looking for kind of any job, and that's how I ended up in infectious disease modelling. I got a postdoc in modelling malaria, looking at different interventions for policy advocacy. And then just a little bit before COVID, I started a fellowship looking at developing new ways to model infectious disease outbreaks, which was pretty fortuitous situation to be in, that I had funding to kind of look at developing methods which initially weren't going to be for COVID, because we didn't know COVID was going to be a thing. Originally they were focused on malaria, but I've spent most of the past year and a half looking at COVID. And you might be wondering why a British person happens to be in New Zealand. Well, unfortunately, I was dating a Kiwi, so we came over through MIQ because he hasn't been home and hasn't seen family in a long time. Just start with some acknowledgements. Most of what I'm presenting today is collaborative work with a number of different people in the School of Public Health at Imperial, and also the Department of Mathematics. There's just a few photos on the screen, but the team at Massel Grönskär is hundreds of people. Just to set the scene, I work in a School of Public Health in an infectious disease modelling department. So there's lots of groups focusing on many different types of diseases. So it's a very different setup to what Mike has here. We're also a WHO collaboration centre for outbreak response, which means that WHO gets contact with the academics in the department if there's an outbreak. So prior to COVID, I've been working on Ebola in the DRC. A little bit about how kind of outbreak response worked prior to COVID. So you have teams on the ground who might realise that they have a new outbreak of something like Ebola. They then get in contact with the World Health Organization. There's a collaboration there where they send data to WHO. Then WHO sometimes contacts Imperial and sends us the data kind of on a fortnightly basis. There's between kind of 5 and 20 people involved kind of doing this analysis, depending on how large scale the outbreak is. We have analysis discussions, number of kind of different iterations, and eventually we produce a report kind of on a fortnightly basis that then gets sent back to WHO. WHO may look at the report and make policy recommendations based on that, or the report might get sent straight to people on the ground, depending on the skill set and where and what stage of the outbreak we're in. But COVID-19, as I'm sure you're aware, is kind of completely different. Prior to lockdown, there's probably similar number of people, 5 to 20 people in the department kind of working on COVID-related things. But as soon as the UK went into lockdown, basically the whole department who could went and started working on COVID. Mostly we were working on Teams, so it was all online. So very, very different to what we were used to before. So in the early days, here's just a kind of timeline about COVID going on in the world. Started off in January, where it started the 31st of December, where the first reported pneumonia unknown case was reported in Wuhan city. Then we get throughout January, COVID starting in China, going through to outside China, hits the USA and Europe towards the end of January, becomes a World Health Organization public emergency. Then in February it gets named, and then in March we start getting kind of large scale numbers of cases. And on the 23rd of March, UK implemented nationwide lockdown. So what were we doing at Imperial? Just a caveat, I wasn't actually working on COVID until we went into lockdown. But there was a small group working in January, and they produced their first report estimating cases in Wuhan on the 17th of January. Kind of early stages, the department took kind of standpoint that they wanted to make our science as open access as possible. So throughout the outbreak, and so we've been producing reports which were preprints, and then the reason they did that is because we wanted to get the science out there as quickly as possible, and then we've gone through peer review later on. The second, or one of the biggest early papers that Imperial looked at, was looking at severity. So this is the CFR, stands for the case fatality ratio. So looking at the number of people who were cases. So a case has to be tested to know that it was a case, and how many of them died. We're looking at kind of 18%. The severity estimates we found very age dependent, and these numbers haven't changed dramatically since the 10th of February, when they were based on very few cases, to now having a huge amount more data. The kind of first difficult report, or first report that had a lot of media attention, was a report on the 16th of March, which I entitled the Lockdown Report, where people in the department looked at what the implications of implementing different non-pharmaceutical interventions were. And we looked at this in the UK and the US. And this is then the first report that showed that perhaps lockdowns would be necessary. So at the early stages of this presentation, I'm going to describe a little bit about the different types of models that can be used for COVID-19. And then I'm going to go on to present some more of the other work about COVID that I've gone on to do outside the kind of main rule. So the first model that's kind of been used and was named the Imperial Model was an individual-based or agent-based model. I'm not sure how familiar the audience is with these different types of models, but the agent-based model looks at following different people in a population. So you have different individuals in your model, and some of them you would give different interventions to. You might have different ages in there. And so your model is up to something that's very complicated. It can take ages to develop these types of models. They can be very computationally demanding. This first model was based on some work that was developed for a flu model, or influenza. So it wasn't specifically targeted for COVID-19, but the problem with COVID-19 was at the start, we didn't really know the dynamics. So we're kind of using the best available code that was out there with the best available updates of parameters. 24th of March 2020, we had the outpour of kind of the UK goes into lockdown, and this is where everything really in the department changed. We were all sent home, and we started working hundreds of people on different aspects of COVID, which is very different to what I hear has gone on here. One of the first things that we did was looking at something called a doubling model. So on the image on the slide, kind of have the different days in March along the bottom, and then the number of deaths. This is quite stark contrast to kind of, we're starting off kind of hundreds of cases in New Zealand, whereas we're having hundreds of deaths in the UK. So with a doubling model, the idea is you're fitting an exponential curve, looking at how quickly the cases will double, kind of giving you an idea of scale of this and how fast it's going to get out of control. So I've just got 3 rough curves drawn on how you fit different models to different parts of the data. You rapidly get very different idea of picture. Slowly it became obvious that this kind of wasn't feasible. It doesn't capture kind of all the dynamics that we have going on. So we had to move away from just this very simple doubling model to developing some more complicated models for what was going on. So now we have our second model, which is something called an SIR, or Susceptive Infectious Recovered Compartmental Model. This model has also been called the Imperial Model, very helpfully. So just as an idea of what a compartmental model is, you have people who you categorize your people in your community into different compartments depending on their infectivity status. And then you have differential equations that describe how you transfer from one compartment to the other. This is the simplest type of this model, this SIR type model. But this is kind of too simple to capture the dynamics. So you start adding on different compartments. For example, your infectious compartment, you now might have people who are infectious who are hospitalized and who are in the community, and the dynamics of the number of people that they go on to infect are different. You would hope that in a hospital setting, the disease is contained, whereas in the community, people may be asymptomatic and not know. And slowly these systems grow, and you get really complicated compartmental model setups. Haven't put the equations on here because they would take pages and pages, but basically it's like the past slide. Here you have, you can see, so you have the S, I, R. Here we have an exposed compartment, and then lots of different sections for in hospital, depending on how severe the disease is and how many people they would go on to infect. Just a bit about how modelling has been done in the UK. There's not just the Imperial Model. By Imperial Model, I refer to that compartmental style model. There's lots of other groups, the London School, that's LSHTM, Warwick, Public Health England. They're all building models which are based on different assumptions, and they all have different uncertainty. Here's just a figure that's taken from the BBC, where this line here is like the government's idea of what a reasonable worst case scenario would be, where all the models are predicting very different results. All the models are based on different assumptions. I'm not entirely sure what's in the other models. I think most of them are now public. There's reports explaining the maths behind them. But depending on what question you're trying to answer, each one of these models may be more applicable. But all these models are feeding into what's going on in the government. But what about the rest of the world? Prior to COVID, our department was very outward focused. We did a lot of modelling for malaria in sub-Saharan Africa and places like this. So we started getting requests from our collaborators about what do we think is going to be happening in the rest of the world. And although we developed the SIR type compartmental model for the UK, this isn't necessarily very applicable to the rest of the world, especially low income, low to middle income countries, where the hospitalization settings, the resources, the very things are very different. If you put the UK into lockdown, yes, people complain, but it's a very different scenario than if you put somewhere in Africa, which is really reliant on bed nets for malaria prevention. If you stop the bed nets getting to people who need them, potentially a lot more people can die of malaria. So we started developing another SIR type model for low income countries, again being referred to as the Imperial College model. For our low income countries, there was a group, I wasn't involved specifically in this piece of work, but they looked at producing these situation reports for countries which were updated in near real time, comparing where different countries were to other countries, and also looking at plots of daily numbers of infections and then the R number. I'm not quite sure how much the R number has appeared in New Zealand, but in the UK, the R number became one of the things that was tracked very carefully. And this is how many people does one infected person go on to infect, with the idea that the epidemic is shrinking if it's below 1, but it's growing above 1. Here's just an example for South Africa. You see the 3 waves where different interventions, different kind of, it started off with strict lockdowns, but as time's progressed, the lockdown or the big measures have got more relaxed. And finally, we come on to the 4th model, which has also been called the Imperial Model. So I think the department needs to get better at its naming. It's called a branching process model, and this is the model that I've been mostly focused on. And the idea with this model is you look at how many people each individual person goes on to infect, and you create this kind of branching process with the different branches being the different people that each generation goes on to infect. And the idea is with this model, you can kind of get an idea for this question mark, how many people is this person going to have gone on to infect? And one way you can do this is an equation called the Renewal Equation. And this is a type of branching process where you have IT as your number of infections is equal to your time varying reproduction number multiplied by the sum of your infections up to the point and then multiplied by their serial interval. So this kind of tells you about how much infectiousness, not that that's a word, is out there in the population. And from that, you can go on to work out what RT is. So again, here are the 4 types of models that the department has been working on. Just a little segue, prior to COVID, I was working on a Hawkes process model. I'm not sure if any of you guys are familiar with that. You're looking at the intensity of a process usually being used for earthquakes or financial modeling, but we applied it to infectious disease modeling, and it has very similar kind of ideas to the Renewal Equation. It's just discrete here. So here we have that the intensity of infection, lambda t, is equal to some kind of background infection intensity. And I looked at applying this for malaria. So you think malaria, you get transmission within country, that's from people to people via a mosquito. But you also get people coming in with malaria over the border. And in countries that are close to eliminating malaria, it's really important to know the kind of contribution from people coming in the border versus not. So we used this Hawkes process to do this. And this is kind of this work, kind of precursor to our work on the Renewal Equation. This isn't very suitable for kind of large scale cases, because for Hawkes processes, you need individual infection times. Whereas with COVID, we were getting hundreds of deaths a day, let alone hundreds of cases. So we started working on that one. So going to go into a bit more detail about the branching process model. This is published in a paper by Flaxman et al. And we're looking at calculating RT to calculate the kind of impact of non-pharmaceutical interventions, or NPIs. So very early on in the outbreak, we didn't have much data. All we were getting in was observed deaths. So countries would report each day how many people died. And we wanted to use kind of that information to work out how good different types of interventions were. Should countries be going into lockdown? Is closing schools enough? But there were methods kind of out there to calculate RT. There's a kind of a very well used package called Epidemiology, and this is based on using cases. And the problem with COVID was that people necessarily didn't know they had COVID. There wasn't testing, so cases were an unreliable form of kind of knowing how much disease was out there. So what we wanted to do was link cases to deaths, and then use the Renewal Equation. So we used the infection fatality ratio to work out how much infection there was based on how many deaths there were, and then we applied the Renewal Equation. So that's why we have these kind of modelled infections in green, and the modelled deaths, and then we fit the modelled deaths to the observed deaths using Bayesian inference, and this is all programmed in STAN. And from this, we were able to kind of get plots which are shown on the right. So we'll start with the middle plot, because in my head that makes the most sense. So this is daily numbers of deaths. So the pink bars are what you see every day. And then we fit this blue model to it, which is kind of our modelled deaths. Then from modelled deaths, we can go to modelled infections. And here you might think, oh, why is there some small pink bars at the bottom? This is the real number of infections, the number of cases that were reported that day. There's kind of 2 reasons why cases don't match infections. One is there was huge underreporting. Different countries had different testing policies. In the UK, at various points in time, you only get a test if you were infectious. You had really bad symptoms. Sometimes even people with symptoms couldn't get tests. And the second reason is lots of people are asymptomatic, so they might have COVID and not know they have COVID, and those asymptomatic people can still go on to infect. And then from this infections plot, we're able to back calculate RT. So you can see that RT kind of is constant and then suddenly it drops off. So there are some icons here which refer to different types of interventions. I can't remember exactly off the top of my head what all of these refer to, but generally the last one is the country goes into full lockdown. And then at that point, you see the drop in RT. So we use this to kind of make estimates of the effect sizes of different interventions. And we found that lockdown is closest to ending transmissibility. So scale above, sorry, the scale along the bottom is a relative reduction in RT. So if it's 0, the intervention had very little impact. And on the right, it has a lot of impact. So the idea with this model was, it's called a partial pooling model. So we use information from different countries to help inform what's going on in all the countries in Europe. I think this was originally set to 11 countries, and then when it was turned into a paper, a few more countries were added because there was kind of a time delay with countries in Europe getting COVID, so there wasn't enough data earlier on for some of our countries. We also looked at the impact of the intervention was implemented first. So there was kind of thought that if an intervention was implemented, it would have a larger effect. But we found that there's kind of not too much difference. In this model, we encoded kind of interventions as a step change. So when the intervention was implemented, kind of our model went from 0 to 1. So there was no kind of smoothing period or like adjustment period for people to start following the rules. It was kind of on the day it was implemented, we changed it. But after that, different organizations around the world started kind of cooperating, and different mobile phone companies and apps, so Google, Facebook, Foursquare started releasing mobility data. So with the idea of this, we get a bit more information than just a start. Yes, there's an intervention implemented by the government, kind of get a feeling for whether people were following these interventions. And at this point, I started focusing on the US, and here is looking at Google mobility trends in part of the US. The states are listed in the legend. You can see that until about 16th of March, kind of mobility was kind of constant, had a 0 change. So we're looking at changes from the baseline. So how much more or less were people moving around in different regions? On the 16th, we suddenly get the solid line dramatically decreases. Google releases lots of different strains of mobility data, so things like workplace, parks, some other things, but they kind of showed the same trend. So apart from the one at the top, which I'll explain afterwards. So we kind of averaged all the ones which are showing the same trend. But the different one was residential, which is what's shown in the dotted line at the top. As people stop going to the workplace, they stop going shopping, residential increase. And we thought it was important to kind of include both of these strains of mobility in our model. Just as a sense of timing, here are the different timings of different interventions in the US. So the first thing they did was generally an emergency decree, which gave each state kind of more power to implement different interventions and also different packages to help people who couldn't go to work and various things. And we're kind of looking in this piece of work at the first kind of stay-at-home or lockdown period in the US. So from when stay-at-home orders were issued to when they were eased. And we went on to calculate over time the probability that RT was less than 1, or the epidemic was growing in each of the different states. And we found that kind of varied. So the probability that RT is less than 1, small or purple, suggests that there's COVID there. Whereas if we have high probability, so these dark green states, the RT is less than 1. We kind of feel that those states have it under control. And we looked at tracking this in real time for a while based on the mobility data. And this got the New York State government interested. So I spent a period of time kind of working with the team, feeding into Governor Cuomo's modelling of New York State. So we took kind of the framework that we developed for the whole of the US and focused specifically on the boroughs. I think that's the term they use in the States for the US, and carefully looked at the impact of different interventions that they were implementing. And it was really interesting working so closely with the policymakers there, and also seeing the data, and it was a very good collaboration. So we've done some more work since then. This isn't a piece of work that I was hugely involved in, but as I'm sure you're aware, variants of COVID came along. So previously we were just focused on kind of one strain. Here, this is an example for Brazil. We suddenly got this P1 variant, which has now been renamed as the Gamma variant. And here you can see that up until like kind of late December 20, all of the COVID was kind of not this new type that then started to come and take over. So we adapted the framework to be able to model multiple strains. This has gone on to not just be used for Gamma in Brazil, but various other strains. And I imagine, although I'm not involved in it, will be being used for the new variant as we speak. So time check. So what I'm focusing on now is, as I was saying before, we're using a pooling model originally. So we're using information about timings of different interventions and different mobilities from different countries to inform RT. But we really were kind of treating each country separately. What I'm working on now is, can we create a fully spatial temporal model where it effectively gets seeded from one infection and watch how this spreads around the country, to kind of give a fuller picture of RT in each of the different areas. We're able to do this for COVID, perhaps because we have good mobility data. And one of the other things we want to look at is how important is good mobility data to predicting the spread. So we've done a lot of kind of work about predicting RT for the Ebola outbreak in the DRC, but there we have very little information about how people are moving. So we want to be able to see is just using a simple model, so gravity, so people are most likely to move close to where they live. How well does that impact, does that predict spread of RT when we actually have decent mobility data? So now I'm kind of having a bit of a gear change in the talk. I'm going to talk about two different applications of different modelling that I've done. The first one is looking at secondary impacts of COVID-19, and I've been looking at orphanhood. This is a very large collaboration across many different organisations that are shown on the slide here. And the idea of this is to provide global minimum estimates of COVID-19 associated orphanhood and caregiver deaths, with the idea that sadly lots of people have died from COVID, but they're leaving behind lots of children who don't have a caregiver. Just as a orphanhood, we describe as loss of one or more parents, which is following the UNICEF definition. So these children may not have lost both their parents, but still, if a child loses a breadwinner or other things, this could still have a severe impact. So here, just categorize the different groups. So we're looking at children who've lost parents, children who've lost a parent or a primary caregiver. In some countries, for example, in South Africa, where there was a large HIV epidemic, lots of children are being looked after by their grandparents. And as I'm sure you're aware, COVID has a higher death rate in old people. And just this is just a side, we found an early, when this paper was first published, so that study goes up to the 30th of April. For every two adults who died, one child was left without a caregiver. Sadly, where the deaths have occurred, this has changed, and we're now getting more than one child left from an adult dying. So how do we do this? Very few countries actually have any record of children who are left behind. So I think Brazil is the only country that we found where on the death certificate they report any dependents that have been left behind from a death. So we started looking at developing a method which would take either the COVID attributed deaths or excess deaths and fertility data, or grandparent household composition data for the grandparent caregivers to predict the number of orphans from each country. We looked at doing this for 21 countries. So we focused on the 21 countries which are labelled on the slide, which had the highest COVID-19 associated deaths with them. We found that the ratio of orphanhood to deaths was highly related to the total fertility rate, as you'd expect. If the fertility rate in a country is higher, and they're more likely to leave behind more children. And we focused on 21 countries, but the idea of this was we wanted to get a number for the world. We wanted to know how large was this problem, and where was this problem. Not all countries release age, sex specific COVID-19 associated deaths. So even if we wanted to and had lots of time, it wasn't possible to extract all the data. So we came up with this, this extrapolation. We now find that on the 30th of September, there's 5 million children who we estimate have lost primary or secondary caregivers. This is quite a big number. And a lot of this work has been used in advocacy by CDC and some of the charities to promote funding to be going to be implemented for these children. And it's been really exciting being involved in this piece of work, because we see governments setting aside certain amounts of money for these children, or different programs being implemented. And it's been nice to feel like, although this is a really sad situation, it's nice that to be able to have been doing something positive for these children. The second piece of work, which is soon to be released as a preprint, is looking at the age distribution of these children. So we have the fertility information, so we know over time how many children each male or female should have of different ages, and from that we can follow it through and work out the composition of the orphans. The majority of them are 10 to 17, which is shown by these big, the largest bars at the top. And the colours look at the sex of the parent. So we don't know, from the fertility information, we don't know the sex of the child, but we do know the sex of the parent. So the blue here refers to children who've lost fathers. We see that the majority, or in some cases 50% of all the children who've been orphaned are adolescents and they've lost a father. There's different implications depending on the age of the children, and also the sex of the parent. If the father in some countries has died, the children may have lost their source of income, and this can have very different and sad implications on children's education. And then finally, this is another piece of topic, something completely different. This is looking at missing cases. So if you have an infectious disease outbreak going on, you may know the people who've been infected and died, but there will be some cases that you don't know. For example, if the case is asymptomatic, no one turns up to testing, or they don't know they have it, so they won't necessarily go and get tested. And contact tracing is a key pillar of outbreak response, as I'm sure you're all aware, with what I think has been a good contact tracing system in New Zealand. But how can you evaluate how well it's working? How do you know if you're getting all the people who are infected in the population, or how many are slipping through the cracks? So we proposed using next generation matrices to do this. I'll go on to explain a little bit more about next generation matrices in the next slide. But first, here's a schematic of the different types of infections. So we classify our infections into 3 types. Red circles are not detected infections. These are the ones that you want to avoid at possible. These are the infections that you don't know about. And then we have 2 more, purple circle and purple square. A purple circle is a detected case that's not under active surveillance. So you still find this case eventually, but you don't know about it, or you don't suspect this person has a case before they get infected. And then this purple square is kind of the gold standard, and you ideally would like all your infections to be purple squares, because then you know about them. I think New Zealand's done reports each day, kind of where people are lying along these different types. And then depending on some probabilities, you end up with 12 different types of infections. So we start off with the first line. So this is the type of cases that are not detected infection can go on to infect. Either you can have a detected case not under active surveillance. So this person would be picked up by routine surveillance. And pi is a proportion of cases detected in the community. So kind of a measure of how good routine surveillance is. If pi is small, the majority of your cases will be the ones you want to avoid, which are the circles. Then depending on how good your contact tracing status is, you kind of get different pathways for this second block, where pi is a proportion of cases that were called by case. So if you have an infected person and they kind of forget how many people they've gone on to contact, it'll end up with a lot of cases in 6 and 7, which are like 1. But with things like the app, pi can be great, can be improved because you now have a record of where you've been, so you're more likely to have a stronger value of pi. Then gamma is the proportion of contacts under active surveillance. So of the people that you recalled, how many of them can they find? For different diseases, this is different. So for example, there's lots of stigma attached to having Ebola. So people may not want to be found. They may give false names of their contacts. They may move, that you might not be able to find them. And then we go into this bottom section, which has the same kind of pathways as the middle section. But we have this alpha parameter here saying that if a detected case, if an infectable case is detective and under active surveillance, they're likely to go on to infect fewer people. For example, you might have them in isolation, where ideally they'd go on to infect nobody. R here is again the reproduction number, and we put it in here to kind of suggest that they're not just necessarily going on to infect one person. This method kind of is agnostic of R. It doesn't really matter what the reproduction number is, but just to show that we're talking about kind of larger scale, multiple people being infected. So to do this, to calculate mu and d, which is our proportion of not detected infections, we use this, we fill in this kind of matrix where we use these pathways here, these kind of symbols here, to fill in this middle matrix to work out kind of how many non-detective cases of the nth generation would we expect. I think this probably needs another n subscript from the first dimension. So here we go, if we just consider the first, filling in the first column, we get this 1 minus pi, because that's the not detected going on to the not detected, then the not detected to the not under active surveillance. Purple is this pi here, and then you can't go on and be an active surveillance case if you're infected from a not detected case. So you go in and fill all the rest of these pathways through. The matrix gets a bit big, so I haven't gone on and filled it in. But then we can look at finding the eigenvalues of this problem, and we find that this leads us to proportion not detected being this analytic kind of equation here. And now we just need to know the proportions of all these different types, all these different pi's and gammas and phi's, and how can we get that? So we look at linking line list and contact tracing databases. This is something that's not necessarily commonly done, or if it is commonly done, isn't necessarily publicly available. But the idea is if you had a list of every case, you would know if they were being followed up before they were infected or not. And from that, we can calculate two ratios, R1, which is a measure of how good your surveillance is, and then R2 is a measure of how good contact tracing is. And this is based on kind of the proportions of each of your cases in your different pathways. So the denominator in both cases is kind of your gold standard. So if the majority of your cases are gold standard, then both these ratios are smaller. And if both these ratios are smaller, the proportion of missing cases is smaller. So we applied this actually to New Zealand SARS-CoV-2. This is just looking at the 2020 outbreak. So none of the more recent stuff. We find that R1 was 0.25 and R2 was 0.2. So these numbers are both low, which straight away suggests that contact tracing and surveillance was going well. From our method, we have, I think, we have 2 more unknown parameters than we have data for. So we use quasi-Bayesian sampling here, where we have, we sampled two of our parameters, and we've been sampling on proportion of cases detected in the community, phi, and scaling and transmission for trace cases alpha, with the idea that if you're working very closely with the people doing the contact tracing and you had amazing access to kind of serology data, you might be able to use other data sources to shrink your priors. So we use 0, 1 priors because we didn't have any more information. Through the way that the case is set up, there's not solutions for all parameter regimes, which is why there's lots of white space. But for our sampling and using these R1 and R2 ratios put into the equations, you end up with this kind of area, which is the possible solution space for all these different possible combinations of alpha and pi. We find that the proportion of not detected infections is lower with this darker blue color when proportion of cases detected in the community. So it's high, as you'd expect, and also when alpha is low. Then we wanted to present kind of some central estimates. So we took the median estimates of all of our parameters. We find that for some parameters like alpha, we have very little information from our method. We almost return our 0, 1 prior. But if we had more information, we could shrink that. So if we knew from serology that the reduction in transmission from a case kind of lay between 0 and 50, then that would shrink the uncertainty in other estimates. And we come to predicting that only about 7% of infections weren't detected. For something like COVID, where lots of infections are asymptomatic, this is pretty good at suggesting that got the majority of infections, even the ones that were asymptomatic. Here's just a few links to the different reports and things that I presented at the start. And any questions or comments. I'm interested in new collaborations. If this is something that's interested you, please get in touch.
Thanks very much, Etty. Now we might have questions from Zoom, so Philippi, I'll let you provide those, but maybe shall we start with people in the room? So yes, Rochelle.
Hi, thanks for your talk. I'm really interested in R numbers, and when you were talking about estimating R after different interventions, did you have any issues where you had countries that put multiple interventions in either at the same time or during sessions? Could your model account for that with oral information? A quick part 2 to the question. I guess you can either bits and cases or deaths and cases of multiple teaching surveillance. Right, that is no longer quite variable delay in some deaths. So do you reckon potentially these are even underestimates for next time, given it's quite early on in the project?
Great questions. For your first one, can you
sorry. I should have cheeky asked you too. If you had interventions.
Okay. Yes, that did happen, and that was a real problem in teasing them apart. that's where we did kind of the pooling. So all the different countries kind of implemented their interventions at different times, but kind of sharing information from countries that maybe put that intervention in first. We were able to kind of tease them apart. And secondly, about cases and death modelling. So we originally just fitted to the death data because that was the best that was available. And yes, there's huge potential, there's huge kind of uncertainty. We kind of used this mostly for Europe because we thought that the death reporting would be best. But in other countries, there's kind of, even in the death data, there's huge swathes missing. So we went on to add in, be able to fit to both in the framework. And potentially developed a package called Epidemiology, which kind of also allows you to add in other data like hospitalizations. You kind of just need to know how your infections relate to that kind of measure. So instead of having an infection fatality ratio, you kind of need an infection hospitalization kind of ratio. That added kind of more complications because the test rate, the testing was varied over time, and then we kind of needed to look at how you could implement a time varying kind of parameter. There was also talk about whether the infection fatality ratio was also varying over time, but we kind of stuck to that being kind of constant.
A question? Can I ask, with the analysis you did with the New Zealand data, what criteria did you use for, what was it, underactive surveillance versus?
So I can't remember which website it was, but there was one that kind of listed something. So I can't remember which one I had, but if we had better data, that's the real problem with these methods. They were developed for Ebola. We were working really closely with WHO, so I physically saw the line list where we had each person linked, but it's not available for everything.
I have a question about the SIR and the branching process-based models. So have you ever looked into identifiability of the extended models, like when you take the basic SIR and add extra brackets and stuff, does it remain identifiable? Or
by identifiable,
like the data you have can distinguish the parameters that you want to distinguish?
So kind of there has been shown links between SIR and branching process models. So you can see, I can lift out a paper if you're interested, how the different parameters in the SIR model match onto a branching process. That method, that the links have been shown there. I don't know if that answers your question.
Yeah, it's just there was recently a serious report that quite a large class of phylogenetic model modify the unidentifiable, meaning that you have plenty of parameters that you can equally infer from the same data. So the data doesn't random guessing on those.
So I've looked at this a little bit more for the Hawkes process model than the branching process model, but it's kind of, they're very similar ideas, one's continuous, one's discrete. The parameters that we fit to, we found that this, depending on how many, if you have too many parameters in your model, you end up with a very flat region where you get non-identifiability. But if you try and just include like the really important ones or use other data to parameterize, for example, we're looking at seasonal forcing. So we had a seasonal term in our background importations, and if we had too many kind of free parameters in there, we ended up with non-identifiability. But if we used information about rainfall to kind of work out how important the seasonal forcing was before we put it into the model, then we could end up with very like sharp points in our optimization surface. I think there is a real risk with infectious disease modeling that people throw in lots of parameters that they try and fit, and you end up with a kind of lots of unidentifiabilities in the system. So I think it's very important to definitely think about that when you're defining your models and try and use as much other data if you can't use that in your joint fitting, to do it first.
I'm just going to ask. Just while we're waiting for that, are there any other questions from the people in the room?
Do you have any explanation why more children have lost fathers than mothers?
So that's based on the fact that more men have died than women. I think there's been lots of kind of thought about why this might be, whether it's depending on kind of the professions that they do, whether they're the ones kind of going out of the house in some countries. Also things like comorbidities, especially in the UK, we find that there's lots of excess death in late middle-aged men. So for example, people have died of heart attacks during lockdown. And we used excess death, not just COVID attributed deaths, because of the issue of underreporting and the fact that each country in the world reports their COVID deaths slightly differently. And we wanted some generic. So I think some of it's the fact that there's just lots of excess deaths, maybe heart disease or unidentified comorbidities.
Is that pattern consistent across countries?
Everywhere except South Africa.
Right.
There was some more women that I don't know.
Oh,
I
right,
don't
you
have.
showed that slide. Yeah.
I think this one doesn't show. I have another figure that I haven't pulled up, but South Africa, you get closer. You just get more women who've died.
Really orphanhood study, is that prompted by government officials asking you to do it? Teams and make one notice the trend and then do the study and present it.
So it comes from a collaboration with the CDC. So they have I can't remember what the exact wording of their team is, but it's domestic violence and child protection. So they noticed that lots of people were dying and had done a lot of work on the HIV pandemic, and they started worrying about the children, and then they reached out to modelers to kind of help them with their estimates.
Well-established protocol of any sort of pandemic like this.
So there has been a tiny amount of work. Well, so they started doing this work for HIV, and there were some estimates. We tried to reach out to people who did those estimates, but the code no longer exists. They couldn't really remember. Somebody had done a little bit of work for the Ebola, West African, the big Ebola outbreak, but nobody had gone into kind of this much detail and kind of globally. It can be quite difficult to go from like study data to a global extrapolation, especially when the best data may perhaps be for the countries with not so severe orphanhood. For example, lots of Africa, they have worse reporting for fertility and deaths. So it was kind of challenging to make sure that we didn't just extrapolate to the globe from high income countries. So we tried to work with as many people as we can kind of in the different countries, and we're starting now to kind of work specifically within countries which have high burdens. So we've done a US specific piece of work, but kind of the US is easy. We have CDC collaborators, but we've got people in Brazil. The department has done quite a lot of work in Brazil, showing from the kind of the RT modelling there. And Brazil's unique that it has actual data. They record the dependencies. So we've been in touch with a lawyer, I think, I'm not exactly sure how, or a judge maybe, who looks at from kind of when the parent dies and what do they do with the children. They have these children going to court and they have to do court orders. She noticed that there was a trend and started recording just in her day job the numbers of children who've been kind of being affected. So we've been working with them to kind of validate the modelling. It's all good and well to put these numbers out there based on kind of assumptions, but how do you know they're right? So we've been working with them to try and get some idea.
Did you consider or look at different age breakdown by sex?
So this is sex of the parent, not sex of the child.
Yeah, but also the age of the parents. Because say like something in that whole world.
Yeah, so we have looked at kind of, I haven't put the slide up here, but we have kind of for each of our 21 study countries, the age of the parents. It's really interesting. It kind of depends on the demography of the country, but in the UK, kind of the parents are kind of older, because the more people who are older are likely to die of COVID. But then in kind of Africa, where the whole population is younger, you kind of see shifted trends.
Are there any Zoom questions?
No Zoom questions.
No Zoom questions. Any more in-person questions? Okay, well, let's thank Etty.